Welcome to Mercy Medical Center's live webinar. I am Lynn Harmon, Program Coordinator, and today's topic is the ABCs of Cancer Genetic Counseling and Testing. Joining us is Kate Durda, Certified Genetic Counselor at the Hall-Perrine Cancer Center. After her discussion, she will take questions from our audience. To submit your questions after the webinar, hover your mouse over the green bar at the top center of your screen and click on the Q&A icon at the far right of the strip. If you don't see the icon, click on the arrow at the very far right and then click on Q&A. Do not click on the chat icon. Then from the drop-down box, select Host and type in your question, and your questions will be confidential. I'm very happy to welcome you to our webinar today, Kate. I'm going to turn the mic over to you now, and we'll go ahead and get started with your presentation.
Thank you, Lynn. I'm very happy to be speaking with everyone today. So I thought we could start out with a brief outline of what I'd like to cover. I've found in my profession that people often have a lot of questions about genetic counseling and genetic testing, and there's also some misconceptions out there about both. So today I would like to talk about what genetic counseling is, explain who genetic counselors are and the type of training that we have, talk about genetic testing for cancer, talk about who may benefit from cancer genetic counseling, discuss issues related to insurance coverage, as well as protection of genetic information, spend a little bit of time talking about cancer genetic research and DNA banking, provide you with some resources, and then, like Lynn said, we'll hopefully have time for questions at the end here. So after the talk today, I hope that people will be able to identify the types of personal or family histories that would be concerning for a cancer genetic counseling evaluation. I would like people to be knowledgeable about the Affordable Care Act and implications that that has had for genetic testing for BRCA 1 and 2, and also to be informed about the Genetic Information Non-Discrimination Act. So what is genetic counseling? Well, this is a definition from the National Society of Genetic Counselors website, but genetic counseling is the process of helping people understand and adapt to their medical, psychological, and familial implications of genetic contributions to disease. So genetic counseling involves collecting information about personal and family history, and then interpreting that information to assess the chance of developing disease or developing another related disease. And then with genetic counseling, we provide inheritance about what the risks are to the patient as well as potentially to other family members. We talk about options that may be available for clinical genetic testing, how those results could influence medical management for patients, what we may be able to do to prevent risk for disease, and then also provide people with resources and research opportunities. Basically, the role of genetic counseling is to promote informed choices so patients can make informed decisions about what they want to be doing with their medical care. So who exactly are genetic counselors? Well, genetic counselors typically are master's-trained healthcare professionals, and they have specialized graduate training in the area of medical genetics and counseling. And typically, genetic counselors work as members of a healthcare team. Genetic counselors work in a variety of different settings, and they may specialize in different areas of medicine. So myself, I practice in cancer genetics, but you may also see genetic counselors in pediatric clinics, in neurology or cardiology clinics, or in your obstetrician or gynecologist office. Today, genetic counselors graduate from one of 30 accredited training programs throughout the United States and Canada, and these are usually 2-year master's trained programs. And the education and training of genetic counselors was formalized in 1969, so this is still a new profession. And in 1971, the first class of master's trained genetic counselors graduated from Sarah Lawrence. So another question that comes up once people understand how genetic counselors are trained is, are genetic counselors certified and or licensed? So yes, genetic counselors, like other healthcare professionals, are certified. Genetic counselors who have gone to an accredited genetic counseling training program are eligible to sit for the board exam, and that is administered by the American Board of Genetic Counseling. And once a counselor has passed their exam, they're then a certified genetic counselor referred to as a CGC. And there are about 2,448 certified genetic counselors in 2008, according to statistics from the certifying board. And according to the National Society of Genetic Counselors, the number of certified genetic counselors has increased 400% since 1992. So it is a growing field. In terms of issues with licensure, genetic counselors are not licensed nationally at this point. It is something that we are working on, and there are obviously a lot of issues beyond the scope of this talk related to that. There are several states now that do offer state licensure for genetic counseling. At this point, Iowa is not one of those states, but if you are in a state that requires licensure, your genetic counselor may be a licensed certified genetic counselor, or may refer to them as a licensed genetic counselor. So there are other professionals who also might provide genetic services. So geneticists are physicians or doctors who are trained with a specialty in genetics, and they've usually done a fellowship in genetics, and they have their own board exam through the American Board of Medical Genetics. You may also hear about genetic nurses. So genetic nurses also have their own certifying board. It used to be the Genetic Nursing Credentialing Commission, and that process is currently undergoing a transition, and I believe will be taken over by the American Nurses Credentialing Center. So these are other types of professionals who may have training in genetics and then gone on to be certified in genetics. So what exactly happens when you meet with a genetic counselor? Well, like I mentioned earlier, the genetic counselor is going to review your personal and family medical history. Now, typically when you're set up for a genetic counseling appointment, you may receive either a questionnaire in the mail or a phone call from the office to try to collect some information from you before your visit so that the genetic counselor can be prepared to discuss some different things for you and do some of the legwork before you come into the office. So when patients are scheduled to see me due to a family or personal history of cancer or colon polyps, they are mailed out a questionnaire that asks about their personal history, as well as asking them to talk to their family members and put down information about the age people are, if people have had a history of cancer or not, types of cancer, and all that information is really helpful to get a risk assessment. So when we meet with a patient, we talk over their family history, see if it's suggestive that there could be something in the family that people are born with, putting them at a higher risk for cancer, and then we talk about genetic testing options that may be available, talk about what those results can mean, and we'll go through some of this in more detail. And then we can also discuss different prevention strategies we might consider based on the personal and family history, and different screenings we might think about as well. So perhaps a patient comes in because she's concerned that her mother had breast cancer in her 30s, and so with that patient we may talk about options to start screening for breast cancer at a younger age or using additional screenings beyond mammography. And then, as I mentioned before, in a genetic counseling visit, you'll typically get some information about whatever disease risk you're coming in for, as well as some general genetics information and different resources that may be of use to you. Genetic counselors, one of the misconceptions about us is that we are therapists. We are not therapists. We're not trained or licensed to be therapists, but we can provide supportive counseling to help people deal with their genetic information and options for genetic testing. But if someone does have significant anxiety or fears about their genetic information and their risk for disease, we may refer them on to a therapist to discuss those in more detail. One thing that I think is really important to know is that genetic counseling does not equal genetic testing. So a lot of times patients may be hesitant to even come meet with someone like myself because they think if they come in, they're definitely going to have to go through a genetic testing, and they're just not sure if they want to do that. That's not true. Genetic counseling is a process to see if genetic testing is even something that would be clinically relevant for people, and to guide people through that decision-making process, give you information so you can make the best decision for you and your family. Genetic testing can have implications for family members. So if we identify a genetic change in a family, there may be risks for siblings, cousins, parents, children to have a genetic change as well, and things we might change about other people's medical care. Genetic testing can obviously have changes for your medical management and help determine your risk for different medical conditions. So like I said, the genetic counselors or other genetic professionals are here to help you learn more about what your options might be and to help you make decisions that are best for you. So let's talk a little bit more about what types of patients may be at risk for a genetic risk for cancer. So we get concerned when we see a family where there's been several family members who have the same or possibly related forms of cancer. So for example, we might see a family history where we have several relatives who've all had colon cancer, or we might see a family history where there's a mix of both breast and ovarian cancer. And those make us suspicious that there could be something going on in the family putting people at a higher risk. We often see these cancers happening at a younger age of onset. So we typically use the age of 50 as kind of a cutoff when we think about both colon and breast cancers. It's more common to see those cancers as people get older, but when we see them under the age of 50, that's usually a red flag to think about having someone visit with a genetics professional. We also get suspicious when we see individuals who've had bilateral cancer or have had more than one primary cancer. So an example of a bilateral cancer would be if a woman is diagnosed with cancer in both of her breasts at the same time, or sometimes women will have a cancer in one breast and then years later may have a cancer in another breast. So that makes us suspicious that that woman could have been born at a higher risk to develop breast cancer. We also get suspicious, for example, if perhaps a woman has had colon cancer and then she also has an uterine cancer. That makes us suspicious for a different type of hereditary cancer syndrome. There are also some cancers that aren't common. So for example, ovarian cancer, if we see a family history of ovarian cancer, we get concerned about possible genetic risk there because ovarian is not a very common cancer to see in the general population. The average woman probably has about a 2% lifetime risk of getting ovarian cancer. So if there is any ovarian cancer, that's a reason that a lot of patients do get referred to me if there's that history in their family. We also get concerned when we see cancers in the less commonly affected sex. So an example here would be if there's a man in the family with breast cancer. It's not very common to see a man with breast cancer. So that would be another type of patient that we would want to see for genetic evaluation. And then we also get concerned when we start to see a cancer without a history of known environmental risk factors. So when we talk about cancer genetics, we break down family histories of cancer into one of three categories. So we have hereditary cancer, which are the cancers where we can pinpoint a genetic risk that people are born with, and then we want to follow them more closely with their cancer surveillance and talk about different preventative strategies. So it's the smallest slice of the pie here. About 5 to 10% of all cancers are hereditary in nature. This larger piece of the pie is the sporadic cancers. And so most cancers do tend to be sporadic in nature, aren't things that people are born at a higher risk to develop. There's also a third slice of the pie here, which are families where we think there's probably some environmental and genetic contributions, but we're not smart enough right now to identify them. So let's talk through these in a little more detail. So as I said, most cancers tend to be sporadic in nature. What this means is typically we only see one person in the family affected with cancer and not at a younger age that we would expect, and it's usually a common type of cancer. So if I had a patient come in because they had a grandmother who had breast cancer in her late 70s, and there's no other family history, a large family tree, that would be a family where I would think that cancer was probably sporadic because it's not uncommon to see postmenopausal breast cancer in women. It is a cancer that all women are at risk for. And so with these sporadic cancers, we really think that they're largely environmentally based, and increasing age does tend to be the largest risk factor there. So if it's a sporadic cancer, we don't think that there's a higher risk for other cancers in the family. Then on the other side of the coin, we have the hereditary cancer. So like I said, this is the smallest slice of the pie, probably up to 10% of all cancers. And these are the cancers where we can pinpoint a specific genetic change, or what we call mutation, that's present in the family, and that puts people who have that change at a higher risk to develop cancer than people in the general population. So we'll talk more about genetic testing for hereditary cancers in a moment here. And then that third category are the familial cancers. So this makes up the remaining 10 to 20% of all cancers. And these are cancers where we may see multiple people in the family with the same type of cancer. We might see multiple generations affected, but we test for all the genes that we know how to clinically test for at this point and can't identify any genetic changes. in these families, depending on what the history looks like, we may still think about different screening recommendations for other family members, and we may still be suspicious that there's something going on that we just don't know how to identify. So we may think about genetic research options for these families if they're interested in that. But clearly, we still have a lot left to learn in medicine, so there's probably some genes that we haven't identified yet or some environmental factors that we haven't realized can cause higher risk within those families. So when you meet with a genetic counselor, they're going to go over your personal and family history to try to see if it looks like it's sporadic, familial, or hereditary. And then based on what they see in your personal and family history, they'll discuss if clinical genetic testing is something to consider for you. And if so, they'll talk through the different testing options that are out there and talk about what those results could mean and options for how those could change recommendations for your medical management. They may also talk about if there are different research studies available, if that's something that you're interested in. So clinical genetic testing is testing that is done in a commercial laboratory, and these laboratories are certified to provide these services. And we compare clinical genetic testing to research testing. Research testing is testing that is not done in a clinical laboratory. It's done in a research laboratory. But we do lots of clinical genetic testing for many diseases, including many different types of cancer today. And so when we talk about clinical genetic testing, this is for patients where we're really suspicious based on their personal or family history that they may carry a genetic risk, putting them at a higher risk of developing cancer. So when we see a family history, one of the things that I don't think people realize is sometimes the patient who's sitting in front of the genetic counselor isn't the most appropriate person to start testing with in the family. When we do genetic testing, we like to start out by testing an individual who's had a history of the disease that we're trying to find an explanation for. So I do see a number of patients who are themselves unaffected, haven't had a history of cancer, but they're coming in because they're concerned about a strong family history of cancer. So for example, say I have a patient who is a 28-year-old woman, no history of cancer, but she's very concerned because her mother had breast cancer in her 40s and she has a couple aunts on that side of the family with breast cancer as well. If I'm meeting with that patient, we'll talk about that we could do testing for her, but it would really give us the most information to start out testing on a relative who's had breast cancer like her mother, because not everyone in a family is going to carry a genetic change that puts them at a higher risk for cancer because of the way these are passed on. So if possible, we like to start out with a family member who's had a history of the disease that we're looking for. Now, of course, we understand that's not always possible. Sometimes relatives have passed away. Sometimes people aren't available for testing for other reasons or might not be interested in testing, but we do have to consider who we're doing the testing on when we interpret exactly what those results mean. Now, there's a lot of different options for genetic testing. There are some diseases that we know are caused just by changes in one single gene. So, for example, the von Hippel-Lindau syndrome, it's a kidney cancer syndrome where we can see risk for other cancers. There's one particular gene associated with that condition. But for some other hereditary cancer syndromes, there can be multiple genes. So Lynch syndrome is a hereditary colon cancer syndrome, and that syndrome has 5 different genes that can cause disease. So there's a lot of different options for testing, and if testing's already been done on someone in the family and there is a genetic change that has been identified, then we will typically start with single-site testing of other family members, looking just for that one particular genetic change instead of looking at the whole region of the gene or genes, and that is a lower cost test as well, so the insurance companies like that. We also today have a lot of different testing options with gene panels. So a gene panel is when we look at a number of different genes at the same time. So we know there are multiple genes that can be involved in colon cancer, so sometimes we have a family history or a personal history where we're not sure if it's suggestive of one particular condition, but there's a kind of a few different things that are on our differential. And so in those cases, we might talk about doing a larger panel that encompasses multiple genes at the same time. And so panel testing is something that's becoming more common. There was some changes in technology and improved technology and decreasing cost, and then also with a few legal things. For example, there was a case in the Supreme Court last year. There used to be one laboratory that had patents on the BRCA1 and 2 genes, and they were the only lab doing that testing in the country. That was overturned a little over a year ago, and so now there are other labs offering testing. And that has kind of changed different options for testing, and so we can do just BRCA1 and 2 testing if we've got a family history where we're really concerned about breast and ovarian cancer, for example, or we may do a larger panel that includes more genes related to breast or ovarian cancer. So I feel like a lot of what I do recently has kind of become options testing and giving people different options for what we could think about for testing and kind of talking through the pros and cons of their options there. Another concern, obviously, with genetic testing is insurance coverage. And I apologize, I didn't cover this earlier, but patients also have concerns about insurance coverage for genetic counseling. So we think of the insurance coverage for genetic counseling and the insurance coverage for genetic testing as two separate issues. In terms of insurance coverage for genetic counseling, we're very fortunate right now at Mercy Hall-Perrine Cancer Center that there is no billing to patients or their insurance for their genetic counseling appointment. There are different ways that genetic counseling appointments can be billed based on the provider who's offering the services and the setting that they're in. So if you are being seen at another office, you may want to ask about that process, and they should be able to give you more information about the types of codes your insurance company would be asking for and if prior authorizations would be needed. But typically, if there's a personal or family history that is suspicious for a genetic condition, there will be insurance coverage for the counseling. So in terms of genetic testing costs, if genetic testing is clinically indicated, meaning that we're really suspicious there could be a genetic change in the family, there typically will be insurance coverage if that's going to affect people's medical management. With genetic testing, costs really can vary depending on the type of testing we're doing. For example, if there's already a known genetic change identified in the family for a cancer syndrome, for testing for other family members, it will usually be in the range of $400 to $475 just to look for one particular genetic change. But if we're talking about doing a larger panel, we can be talking several $1,000s. And so that's not a small amount of money to think about. So if testing is indicated based on current professional guidelines, typically most insurance companies will cover testing. Of course, there's always loopholes with different policies, so we can do pre-verifications through the laboratories that do the testing to verify patients' coverage before we actually order any testing. And I find that's what a lot of people like to do first, is to have an idea of what you're getting into and what your out-of-pocket cost may be. With the insurance coverage, if someone does not have complete coverage for their genetic testing, depending on their medical history and their financial situation, there may be national and also local groups that may be able to help offset their genetic testing costs. So that's something that we also talk about with patients, or different options that may exist. But typically, if the testing is clinically indicated, most patients will have coverage. Of course, there are a few insurance policies out there that do have exclusions for genetic testing, so there's always a few loopholes, but it's something that once you've met with someone in genetics and they've gone over your history and family history, they can give a better idea of if you meet professional guidelines, and then if there's particular things about your insurance company that they know of up front. And then the other thing to mention here is, even if someone is offered genetic testing, it doesn't mean that they have to do it. And so I meet with plenty of people where we talk about genetic testing options, and they decide that it's not something they want to do at this time for whatever reason, and that's perfectly fine. I often meet with people and they kind of want to get more information about what the genetic testing could mean for them and for their family, and they want to go home and process that information, maybe look at some of the resources that I've provided them with, and kind of talk through these issues with their family, and then make a decision about whether or not they'd like to do testing, and then they can come back in and have testing. In terms of what genetic testing actually involves, patients provide written informed consent saying that they're agreeing to have the testing done. And then genetic testing typically involves giving either a blood, a saliva, or a mouthwash sample, and we send that off to the commercial lab, who then extracts the DNA from that sample. So it's not, sometimes people think it's a very painful process. Really, the most pain is if you have a blood draw, but for a lot of the testing, we can just have you spit into a tube, and we're collecting the cheek cells from that, which contain the same DNA that's present in your blood. So let's talk about if someone does choose to do genetic testing, how those results could come back. So there's 3 different things that can happen. We can find a positive result, which means that we identify a genetic change or a mutation in the family that causes a higher risk for disease. In this case, we fall back on either a professional or expert-based guidelines to talk about cancer prevention and surveillance options that are out there for the patient. And then we talk about the importance of sharing that information with family members so that other family members can have that single-site testing just for that particular mutation to see if they have a higher cancer risk. It's also possible when we do genetic testing that we can get a negative result. This means that no genetic changes have been identified. So when we get a negative result, we have to think carefully about what we know about that person's individual history as well as their family history. So I said we prefer to start out testing in someone who's had a history of disease. So if it's a patient who themselves has not had a history of disease but has a strong family history and we get a negative result, we may still think about increased screening for that individual because we can't say that her relatives who had cancer had a genetic change that she just hadn't inherited. So we have to be careful with how we interpret the negatives. It's also possible that we can get a variant of uncertain significance, and this is kind of a gray area. And this is a very frustrating result for patients and families as well as for healthcare providers. This is a change in the gene where the laboratory does not feel that they have enough information to say if it's really a positive or a negative result. So when we find a variant, we need to do more research to try to figure out exactly what that genetic change means. Is it a change that puts someone at a higher lifetime risk to develop cancer? Or is it maybe just some normal variation within the gene, an alternative spelling of the gene, and something that's a benign finding? When we find a variant, we do not want to test other relatives clinically for that. We don't want to use it for clinical management. We want to fall back on the family history to make recommendations for screening. But we may talk about research testing options for the family. So with a variant, the hope is that with more research, we can get that reclassified to be either a positive or a negative result. And typically most laboratories follow those variants and would report any updates back to the genetic counselor or healthcare provider who ordered your testing, and then that individual will contact you with that information. So when we do genetic testing, sometimes we get straightforward answers, sometimes we're still left scratching our heads, so we obviously have more to learn, and that's why we'll talk about some research options in a little bit here as well. In terms of what genetic testing results mean for medical management, so we have different professional guidelines for cancer surveillance based on people's personal or family histories. And typically, if we find, we'll talk about BRCA1 and 2 for hereditary breast and ovarian cancer. So typically, if we find that someone has a change in the BRCA1 or BRCA2 genes, we'll think about starting screening them for cancers at a younger age. So for women, we think about starting to do imaging for breast cancer in their mid-20s. We also think about screening men for breast cancer in their 30s and men for prostate cancer in their 40s, and then women for ovarian cancer. So with breast cancer risk, we often think about using additional screening. So mammography is recommended for all women of a certain age, but if a woman does have a higher risk to get breast cancer, we may think about also doing things like breast MRI surveillance and other type of imaging to look at the breast tissue that may pick up some things that we might not see on the mammogram. So the recommendations that we typically follow are put out by the National Comprehensive Cancer Network, and that's a group of professionals from different medical specialties, and they review the new research data and update these guidelines at least annually, usually more than once a year. We also can talk, besides just screening and trying to catch cancer at an earlier stage when it might be most treatable, we can discuss different cancer prevention strategies. So typically those involve options for chemo prevention, taking a medication to try to decrease the risk of a cancer occurring or reoccurring, and then also talking about prophylactic surgery options as well. And just because someone chooses to go through genetic testing, if they were to get a positive result showing they had a higher cancer risk, it doesn't mean that they would have to do any of the screenings or the chemo prevention or prophylactic surgery. It just means that those are different options that are out there for them to explore, and we typically encourage people to talk to the specialist involved with each of those areas to hear more about, you know, the pros and cons of things, to be aware of what their options are. In terms of cancer risk assessment, I've mentioned that even if someone doesn't have a genetic change, depending on what their history and family history is, we may think about different screenings for them if we think they have a higher risk. So I do see a lot of patients because of family histories of breast cancer, and so even if someone is eligible for genetic testing, if we're really suspicious there could be a change in their family, but they don't want to do testing at this point, there are some different things we can do to assess their risk. So there's different models that take into account a woman's personal history as well as things about her family history and can give us estimates of her risk for breast cancer. So one model that you might hear about is the Gale model. This is a model that's mainly based on personal risk factors for breast cancer, but can also include close relatives who've had a history of breast cancer. And we use this to evaluate which patients might benefit from chemo prevention for breast cancer by looking at what their 5-year risk of breast cancer is compared to the average woman. And then there's also several models that we use to think about which women we might think about increased breast surveillance for, so typically thinking about doing breast MRIs as well as mammograms. And so these models, the Tyrer-Cuzick model, BRCA Pro, Klaus, and Boadicea are kind of the common models that are used, and these can give us an estimated lifetime risk of breast cancer. And depending on the models, they incorporate some family history information, you know, relatives who have and haven't had cancer, ages people were diagnosed with cancer, as well as some personal risk factors for women as well. So like I said, genetic counseling does not equal genetic testing. There are other things you can gain from a genetic counseling visit. Even if you don't think you want to do genetic testing at this point, our role is to kind of help you understand what your risks may be and what we can do to mitigate those. So let's change gears a little bit and talk about a few insurance issues. So I often get questions about insurance issues. So if I am found to have a genetic change, will I be discriminated against? Can I still get insurance? How will this affect my family members? There is a law called GINA for short, so that's the Genetic Information Non-Discrimination Act, and this was passed in 2008. And this was passed to try to remove some of the barriers so that people could get appropriate genetic testing if they wanted. So what GINA does is it protects individuals from the misuse of genetic information with their health insurance and also their employment. So this only applies to patients who haven't had a history of disease. So if someone has already had a cancer diagnosis, GINA would not apply to them. This applies to those people who have a family history of disease but haven't had a personal history. So if someone is found to have a genetic change that puts them at a higher risk to potentially develop cancer, their health insurer can't hold that against them as a pre-existing condition. They can't be dropped from their policy. They can't have their rates or premiums changed based on that information. There are also employment protections. If an employer were to learn of someone's results, they can't hold those against them in any way. And I should say I am not an insurance specialist. I am not a lawyer, so I will give you a few resources at the end of the talk where you can read more specific examples about GINA, but this is just kind of a general overview. So what GINA doesn't do. Unfortunately, this law is not perfect. So I mentioned already it does not protect information about current health status. So if somebody already has a diagnosis of cancer or another genetically related disease, they won't be covered under GINA. It's just for individuals who have a higher risk and haven't been diagnosed with a disease. GINA does not apply to other types of insurance policies. Unfortunately, right now, GINA does not apply to life, disability, or long-term care insurance plans. Those plans can consider a genetic risk a pre-existing condition. So it is something I think people need to know about before they do their genetic testing, what these loopholes are. And so some people do want to look into their life, disability, or long-term care policies before we do their individual testing. If you have a policy in place, we do testing and get a positive result, that policy still holds. But if you haven't set up a policy yet and we get a positive result, you may run into issues getting the life, disability, or long-term care coverage that you'd like. As always, there are some loopholes with different insurers. So GINA doesn't apply within certain health systems. They do have their own regulations. This includes the United States military, the Veterans Administration, Indian Health Service, and Federal Employees Health Benefits programs. The employment part of GINA does not apply to employers who have fewer than 15 employees, but the healthcare part of the law does apply. And I'll give you a couple of resources at the end where you can read more about GINA if that's of interest to you. And then we've already mentioned with GINA too that it's just for unaffected people who had a higher risk. Once someone is diagnosed or showing signs or symptoms of a disease, they're no longer covered under this law, unfortunately. So let's talk about another insurance issue. So the Affordable Care Act is causing a lot of changes in medicine, as I'm sure you're aware. One thing that I think is a positive for genetics under the Affordable Care Act are some changes with coverage of BRCA1 and BRCA2 genetic counseling and also genetic testing. Under the Affordable Care Act, this genetic testing and counseling is considered a preventative service. That means there is no patient cost sharing if their insurance plan falls under the correct designations here. If the patient has a family history that meets particular criteria put out by the United States Preventative Services Task Force. So again, there are some limitations with which policies this applies to and which it doesn't. Unfortunately, at this point, it does not cover Medicare, Medicaid, Blue Cross Blue Shield, Federal, or TRICARE. There are also limitations with grandfathered plans, and under those plans, there may be cost sharing for preventative services. The recommendation statement is available online, and I'll show this again in the resources at the end of the talk. But basically, the guidelines that were put forth by the Preventative Services Task Force are based on professional criteria about which patients were suspicious could have a genetic risk for a BRCA1 or 2 change. Unfortunately, this only applies to women right now, even though we know there are cancer risks for men in these families. And the hope, I think, is that genetic testing for other conditions where we can do things to prevent or detect at earlier ages hopefully will start to get better insurance coverage. But with the Affordable Care Act, patients who do have a family history suspicious for a change in one of these BRCA1 or 2 genes may be able to get their genetic counseling and genetic testing at no out-of-pocket cost to themselves. So we've started to show that there really is value to identifying these patients at a higher risk. We've talked about how there's still a lot left to learn in genetics and in medicine. So we've talked about how even if we're really suspicious of a family history and that we'll find a genetic change, we may get negative test results and not identify what's going on. So there are different research studies out there, and research studies, of course, are completely voluntary. And so if patients are interested, typically a genetic counselor can help identify studies they might be eligible for and get them enrolled in those if they're interested. There are cancer studies that are just for patients with any personal or family history of cancer. There are also different disease-specific research studies, so studies on patients with prostate cancer, or studies on patients with changes in a particular gene to learn more about other genes or environmental factors that might cause a higher cancer risk. Clinicaltrials.gov is a great place to look for available research studies or ask your healthcare providers as well. We are really excited that we have a cancer genetic research registry study here at Hall-Perrine Cancer Center, and participation in this study is open to all patients who are seen for cancer-related genetic counseling here. and participation involves providing informed consent, agreeing to the research study, which has been approved by our institutional review board, and then after patients provided informed consent, giving a sample that will be sent off to the laboratory for research, and then also completing a questionnaire about your history and family history, which is information that's collected as part of the actual genetic counseling visit as well. So this is something we're really excited to be able to offer to people, but there's also other research studies out there that we can discuss with patients and families as well, and the hope is that through research that we will learn more about cancer genetics and what causes higher risk for cancer, and then be able to use that information to try to detect cancers earlier on or do things to prevent them. So I would like to talk just briefly about DNA banking. I'm not sure if this is something people have heard about, but this goes back to that idea that we still have a lot left to learn in medicine. So DNA banking is the act of actually taking a sample of an individual's DNA and having that stored in a freezer in a laboratory. And so the idea here is that if we test for all the changes in genes that may cause a history of ovarian cancer at this point, and we can't pinpoint a change within the family, and there's multiple relatives who've had ovarian cancer, the family might want to think about having a relative store their sample so that if additional testing becomes available in the future and that relative may no longer be available to give a sample, there's an informative sample for the family to go back to. Unfortunately, at this point, DNA banking typically is not covered by insurance policies. However, it might not be as cost prohibitive as people think. There are some different commercial laboratories that offer this testing. There's one laboratory that I know charges around $100 to store a sample for about 20 years. So it's not an unreasonable amount of money to consider in terms of how this may help family members down the road if we do identify new genetic changes. So in summary, thank you so much for your attention and your time. I know we've tried to cover a lot, but we reviewed some of the risk factors to identify patients who may be at risk for hereditary cancer syndrome. We've reviewed information about the Affordable Care Act and the implications that has for BRCA1 and 2 genetic testing, and we've also reviewed information about the Genetic Information Non-Discrimination Act. So I'd like to end here with a few different resources. The National Society of Genetic Counselors I mentioned earlier on in my talk, but this is the National Professional Organization for Genetic Counselors, and you can look at their website to learn more about how to locate a genetic counselor. They have a Find a Counselor feature to locate a genetic counselor in your geographical area. They have information about what to expect during a genetic counseling session, and information for people who may be interested in a career in genetic counseling as well. The American Board of Genetic Counseling, again, that's the certifying group for genetic counselors in the United States, and you can look up and check someone's certifications on this website. You can learn more about genetic counselors and about careers in genetic counseling. The National Comprehensive Cancer Network has nice resources both for healthcare providers and for patients, and they are the ones who come out with the guidelines that we're typically using to follow patients. The American Society of Human Genetics and the American College of Medical Genetics are two other professional organizations for genetic professionals in the United States, and their websites both have additional information about genetic counseling, genetic testing, and all of that. And then the Genetic Information Non-Discrimination Act, two really great websites, GinaHelp.org and DNAPolicy.org. I would really encourage people to look at those if they have more questions about genetic discrimination issues. There's also another great site that I apologize is not on this list. It's the Cancer Legal Resource Center, and that's a group that is well-trained in insurance and legal issues. And so if you just Google Cancer Legal Resource Center, their website will come up. But if you have particular questions about legal issues with diagnoses of cancer and things of that nature, they do have support mechanisms to answer those questions for you, and they're a great group, and they do periodically do webinars as well on different topics. The Affordable Care Act link for more information about which types of patients may be covered for BRCA1 and 2 testing. And then this last site is a link to a blog post by a genetic counselor talking about the top 10 common misconceptions about genetic counselors and genetic testing. So it covers a lot of what we went over today, but you can hear it from someone else's perspective, but kind of the common questions that we get are the common misconceptions people may have about this field. So thank you so much for your time. I'm going to hand the mic back over to Lynn, and then I think we'll have time for questions.
Well, thank you, Kate, for a very thorough presentation, information about genetic counseling and testing. I want to remind our listeners that your questions can be submitted by hovering your mouse over the green bar at the top of your screen. I'm also showing on the screen right now information, Kate's information, her email address, phone number to contact her, as well as a phone number for scheduling if you are interested in considering a counseling appointment. Get to our first question here. If I have the gene, should my children be tested right away? Now, this is kind of specific. I'll let you kind of generalize, Kate, in answering this question.
Thanks for the question. So that's a great question. If you do find that you have a gene, a genetic change putting you at higher risk for disease, what should we think about for your children? Well, it really depends on what gene we're talking about and how old your children are and what their medical history is. Typically, with hereditary cancer syndromes, testing is not offered to children until they're at least 18 years of age when they can legally consent to the testing themselves. Part of the reason for that is that we don't want them to run into issues with discrimination with the life insurance, long-term care, disability insurance plans. The other part of that is about their medical management. With most of these hereditary cancer syndromes, we're not changing things about people's medical management until they're in their 20s and their 30s. Of course, there are a few exceptions to that. If there is a genetic condition in the family putting people at risk while they are children, then yes, we will consider doing genetic testing for people under the age of 18. One particular example for cancer genetics is some of the colon polyp syndromes where people have a really high risk of developing colon polyps and therefore have a higher risk for colon cancers. Some of those we can see childhood onset of those diseases. So if there's a family history of familial adenomatous polyposis syndrome, for example, we may test patients at a younger age because we would be changing things about their medical care before they're 18. But I would encourage you to talk with your healthcare providers about exactly what condition you have in the gene and if there would be changes to your kids' medical care at this point, and go from there.
Our next question, should I see Kate or our counselor if her mother has died and a first cousin has also died of pancreatic cancer?
Another great question, thank you. So with pancreatic cancer, again, that's not the most common type of cancer to see people develop. And so if we do see multiple family members who are closely related, so both your mother and your first cousin would be considered closely related relatives, it would be something to consider a genetic evaluation to come in and talk about the family history. With pancreatic cancer, that is one cancer where there isn't just one particular gene we know of that can cause higher risk. We can see pancreatic cancer as a part of multiple different cancer genetic syndromes, and in some families we're still left scratching our heads as to what's going on, but there are different research studies specific to cancer, pancreatic cancer genetics as well. So if this is something you're interested in, please do get in contact to meet with a genetics professional and we can talk more about those issues.
Does your counseling include environmental risk factors as well as the genetic risk factors, for example, tobacco use?
So we will ask about different risk factors that may cause certain types of cancer. So you mentioned tobacco use, so yes, typically that's a risk factor for lung cancer, for certain types of bladder cancers. So if we see a relative with those, we may ask if they were a smoker or not to help try to figure out if those cancers may be sporadic in nature and due to environmental things. We also ask, for example, with pancreatic cancer, ask about history of diabetes, as well as history of smoking, because those are risk factors as well for pancreatic cancer. Typically, the risk factors we ask about for breast cancer for women include information about if a woman's used hormone replacement therapy and things of that nature that we factor in. We know that we all have, healthy behaviors we should be doing with diet and exercise and everything, and those are true for people who have a genetic risk to develop cancer as well, to follow those same guidelines.
Kate, what percent of patients that you counsel are tested and then found to actually be positive?
That's a tricky question. It's really an individual decision if people want to do testing or not, and I do see some families or patients who come in and their history is not really suggestive of a hereditary component, and so those patients aren't offered clinical testing, but I do see patients who I will offer clinical testing, and some people don't want to take me up on it. Some people have concerns about anxiety if they're found to have a genetic change. Some people just, already are fearful if they have a personal or family history of cancer. And then sometimes there may be issues with coverage of their genetic testing and concerns about cost if they don't have insurance coverage. So I can't give you a great answer in terms of the percent who go through with testing or the percent who are found to be positive. When you're doing genetic testing, the percent who are found to be positive really depends on what the likelihood was of finding a change in them beforehand. So it's really an individual decision if people want to do the genetic testing or not, and then based on how strongly suspicious we were, whether or not those results come back positive. And even in those patients where we don't get a positive result, we still may think about increased screenings like we've talked about today. So the positive result isn't the whole picture here, because we might already have things we think about recommending for additional screenings within the family.
Okay. Can you tell me the difference between genetic counseling for cancer versus birth defects? That you mentioned this earlier in your presentation.
Yeah, so I mentioned that genetic counselors may practice in different medical specialties, and so all genetic counselors right now go through the same training programs regardless of what specialty they may end up practicing in, and all genetic counselors take the same certifying exam, which covers information about all different genetic conditions, but I consider myself a cancer genetic counselor. That's the area I've practiced in professionally for several years now, and I've got additional education beyond my master's in cancer. And there are some counselors who may focus on other diseases. So I have colleagues who focus just on prenatal genetics, so they may meet with patients who are considering a pregnancy to talk about carrier screening for diseases that may be more common in individuals from their ethnic background. They may meet with patients who are pregnant and talk about different screenings that can be done and different tests that can be done during pregnancy. There are counselors as well who specialize in different neurological disease. But basically, we all have the same initial training and certification, and then we go on through our professional work to learn more in these areas and acquire additional training in particular areas. There are also some counselors who practice in just a general genetic clinic where they may see a variety of different patients for different reasons. So it kind of depends on the counselor's interest and what the availability of different positions are in their geographical location.
Kate, you mentioned DNA banking. Is this available locally?
So there are several different commercial labs that do DNA banking throughout the country. I'm not aware of one locally within, the Cedar Rapids area. There is a company that is north of us in another state that patients have used before, but we're just trying to get the word out to make people more aware of DNA banking and the information this could potentially provide their families down the road. So it's something that every patient who meets with me gets a little brochure about DNA banking, and we're just trying to make both patients and healthcare providers more aware of this opportunity if it's something they want to proceed with.
Question. My mother died of ovarian cancer, and my sister had a hysterectomy as a preventative measure. Would I be a good candidate for counseling or testing?
So another great question. Ovarian cancer, as I mentioned earlier, is not a common cancer to see. Like I said, it's probably about a 2% lifetime risk for the average woman to get ovarian cancer. So if there is any diagnosis of ovarian cancer in a patient or in a close relative, you may want to speak with your healthcare provider and consider a genetic evaluation, talk about the options that are clinically available for genetic testing or different screenings that may be considered. So I would encourage you to speak with your healthcare providers about that.
I believe we've covered all the questions for now, but as we wait, I want to point out that our next webinar topic is oral head and neck cancer with Dr. Vincent Reed. He's the medical director at the Hall-Perrine Cancer Center, and his webinar will be Thursday, August 28th from noon to 1, and as we've done with Kate, he will take your questions live after the presentations. And you can register at mercycare.org/live. Now, a tape of today's program will also be available at this web address, the /live, and it's usually posted within a day or so. So if there's something you missed in Kate's presentation or you want to share this with a family member, just go to this website and click on our archived link, and you'll be able to listen to Kate's presentation as well as the various other webinars we have posted there. If you are interested in future Mercy webinars or other events, you may also sign up for Mercy's electronic newsletter at mercycare.org/e-news. Okay, I believe we have covered all the questions that have been submitted to us today. But again, if you have additional concerns or questions that you think about after our presentation ends, Kate can be reached at the number on the screen, 221-8689, or her email address, or if you are interested in going ahead and scheduling an appointment, that number 319-861-7778. Thank you for joining us today.